This is a presentation of a case study of a pediatric patient. The case study will be based off of MRSA. Our case study will include a 12-year-old male that presents to his primary care office with complaints of an abscess that he is currently being treated for with oral Bactrim and topical mupirocin. His abscess is located on his chin, and he stated that he acquired this abscess by picking at a pimple. The abscess has increased in size tremendously since the first time he was seen, and he now has streaking of the side of his left mandibular area. He also complains of a new abscess that is on his buttock and also has a new onset of symptoms. His new symptoms include fever, chills, dizziness, confusion, and muscle pain. He is directly admitted to a local pediatric hospital for further testing and treatment. Pertinent information for this patient would include his vital signs at the office visit. His temperature is 102.6 taken orally. His blood pressure was 102/78. Pulse was 128. Respirations 24. He rates his pain a 6 on a scale of 0 to 10. Patient has no known allergies. His current medications include Bactrim twice a day, mupirocin ointment applied to the abscess on his chin, Claritin daily, and a multivitamin daily. The patient's history includes a past medical history of seasonal allergies, pneumonia, and constipation. He has not had any prior skin complications. He was a full-term healthy newborn baby and has been a healthy child up until now. He has never been hospitalized before. He has failed outpatient therapy with Bactrim and mupirocin ointment. What are some questions we can ask about this patient? What could this patient's diagnosis be? What kinds of labs should we order for this patient? Since he has failed outpatient therapy, what kind of medications would we start him on now? What kind of education would be provided for this patient and his family during and after his hospital stay? Answers to these questions could be an initial diagnosis of cellulitis secondary to an abscess on his chin. We can also diagnose a second abscess on his buttock. Labs that may be drawn or collected would include a CBC, CRP, BMP, sed rate, blood culture, and a wound culture. New medications we could start him on during his hospitalization are IV clindamycin, IV vancomycin, topical mupirocin that would be administered in his nasal cavities and possibly his rectum. Some education we could give for the patient and his family would be to educate them that during their hospital stay, he would be evaluated for the first 24 hours to see if the antibiotics are making any improvement in the abscess. If no improvement is noted, then the patient may need surgical incision of the abscess and need to continue IV antibiotics during his hospital stay. He will need to take chlorhexidine baths at least twice a day, and once he is discharged, he will need to continue with these baths. Parents or caregivers need to be instructed that all household surfaces will need to be kept clean with bleach for at least 8 weeks after he has been discharged. If the wound requires being packed after his surgery, then this should be demonstrated verbally and hands-on. His caregiver or parent should give a return demonstration of how to pack the wound prior to being discharged. Some drugs of choice we would use are clindamycin, vancomycin, topical mupirocin, and Nosin 360. Nosin 360 is a new nasal sanitizer that's been introduced to the hospital setting. It helps to reduce the spread of nosocomial infections and helps to reduce pathogenic bacteria in healthcare settings. It's not actually considered a medication, but since it is new, I thought I would place it into this PowerPoint. Clindamycin is an antibiotic that is used to treat anaerobic streptococcal and staphylococcal infections. Vancomycin is a glycopeptide narrow-spectrum antibiotic used to treat many types of infections that are resistant to other drugs, such as MRSA. Topical mupirocin is a bactericidal antibiotic that has a wide range of coverage against gram-positive bacterial infections, and it also has some coverage against gram-negative bacterial infections. High-risk populations for these medications. Clindamycin would be pregnant women. It is considered a pregnancy category B due to the lack of studies, and the drug can cross the placenta during pregnancy. It is advised to avoid use in neonates due to the high alcohol content, which can cause organ system dysfunction. Renal, hepatic, or elderly patients used with caution due to half-life is prolonged and could increase potential for adverse events. Vancomycin, not recommended during pregnancy due to fetal malformations seen in animal studies. May reduce systemic and renal clearance in geriatric patients, so should be avoided in them as well. Topical mupirocin, fatal toxicity in neonates, avoid use, can cause gasping syndrome, CNS dysfunction, and hypotension in the neonate. Currently, there are no known high-risk populations for Nosen 360, but I would not believe it would be recommended for neonates. Drug interactions for these medications. Clindamycin should not be administered with rifampin due to the decreased serum concentrations. Do not administer with any neuromuscular blocking agents due to clindamycin having neuromuscular blocking properties. Vancomycin may enhance nephrotoxic effects with aminoglycides, may diminish therapeutic effects with BCG, may diminish therapeutic effect when used with bile acid sequestrants, may diminish therapeutic effects of lactobacillus, may enhance neuromuscular blocking effects when used with neuromuscular blocking agents. Anti-inflammatory agents may increase serum concentration of vancomycin. Piperacillin may enhance nephrotoxicity, so should not be used in conjunction with vancomycin. Mupirocin currently has no known significant interactions, and neither does Nosen 360. Mechanism of action for these drugs. Clindamycin is a bacteriostatic antibiotic that is bactericidal in some cases. It binds to the 50S ribosomal subunit of bacteria, disrupts protein synthesis, and inhibits early chain elongation. Potentiates opsonization and phagocytosis of bacteria, disrupts bacterial protein synthesis, causes change within the cell walls, causing a decrease of bacteria being able to adhere to the host cells. This process increases intracellular killing. Vancomycin inhibits bacterial cell wall synthesis, blocks glycopeptide polymerization, and binds tightly to a portion of the cell wall precursor. Mupirocin binds to bacterial transfer RNA synthetase and inhibits protein synthesis. Nosen 360 activates as a broad-spectrum antimicrobial agent to ward off spread of infection. IV clindamycin medication dosage is 20 to 40 milligrams per kilogram per day. This is divided in doses every 6 to 8 hours for a pediatric dosage. Pediatric dosage of IV vancomycin would be 45 to 60 milligrams per kilogram per day, also divided doses every 6 to 8 hours. Time serum trough levels need to be drawn to determine proper dosage for future administration of IV vancomycin. Mupirocin is 500 milligrams BID to the nares for 5 to 10 days for MRSA. And Nosen 360 is one measured application to the nares. Some common side effects for these medications. Clindamycin, diarrhea is the #1 side effect. Allergic reactions, local reactions such as thrombophlebitis at the infusion site. Vancomycin, the patient can have hypotension, neutropenia, local phlebitis, chills, fever, and a common rash known as red man syndrome. Often patients break out with red man syndrome. They get really red on the back of their neck, sometimes on their face, and can even look like they have hives on the trunk and extremities. With my experience of vancomycin, often the physician will tell you to turn the rate down and see if the rash improves. If not, the medication is often stopped. Mupirocin can cause headache, localized burning, and/or stinging, a rash, nausea, local pain, cough, congestion, or pharyngitis. Nosin 360, there currently are no pertinent side effects known of, but it could cause some burning sensation of the nares. Metabolism and excretion of these medications. Clindamycin is metabolized by the liver into active and inactive metabolites, and it's excreted in the bile and urine. Vancomycin, its metabolism is unknown. It is excreted renally if IV or through the feces if given orally. Mupiricin's metabolism and excretion is unknown due to the low systemic absorption of the medication. And Nosin 360, there is no known data. Absorption and distribution of these drugs. Clindamycin is absorbed through pleural and peritoneal fluids, distributed in body fluids, tissue, and bone, but does not reach the CSF fluid. It diffuses across the placenta and can be found in the breast milk. Vancomycin absorption is through intravenous fluid and distributed widely by penetration of the CSF. It can cross the placenta. Mupirocin is absorbed through the skin. If it is applied to large areas of abraded skin, it is absorbed deeper. Limited data on how it is absorbed in the nares, and distribution is unknown. Nosin 360 is absorbed through the nares. Distribution is also unknown of it. Our final diagnosis before discharge of this patient would be MRSA secondary to multiple abscess and cellulitis. This diagnosis was made based off of wound culture results prior to his discharge. Although he initially appeared very ill and may have been approaching the first stage of sepsis due to his infection at his office visit, part of this could have been due to his body temperature. Body temperature in response to an infection can often cause vital signs to be out of normal range. His heart rate was elevated, his respiratory rate was elevated, and sometimes our blood pressure could even be a little bit elevated. He is improved and was discharged home after his surgical incision and several days of IV antibiotics. He was given discharge instructions on how to further prevent abscesses and MRSA infections. His family members were also given very thorough instructions on how to avoid further infection for this child and for themselves and other family members. This concludes my case study on MRSA in the pediatric patient. Thank you.